get started. Well, thank you very much for your participation, for being here. We're glad to welcome you to this series of webinars on nutrition in emergencies in the context of COVID-19 and migration that were organized by the Regional Nutrition Sector, specifically by the UNICEF Regional Office for Latin America and the Caribbean, in collaboration with the Global Nutrition Cluster Technical Alliance. So this webinar series was organized in the wake of COVID-19 crisis that has forced us to change our ways of working, and this is requiring adaptations of nutrition activities, of nutrition response activities. Also, we are seeing in a region different migration flows from Venezuela, but also from Central America to Mexico and the United States, but also international migration and migration from the Caribbean and South America that go through Panama to go to the north. And in this context, the nutritional status of vulnerable groups is at risk. So this webinar series, well, the objective is to bring, to provide you with knowledge and tools regarding different topics on nutrition in emergencies. The first one that we will be presenting today is the prevention of malnutrition in pregnant and breastfeeding women. Next week, we will be presenting on the prevention of malnutrition in children under 5, specifically focused on infant and young child feeding, so breastfeeding, complementary feeding, and support of the non-breastfed child, but also supplementation. And in 2 weeks' time, we will be presenting about the nutrition care for children under 5 with acute malnutrition. So this webinar series targets personnel working in emergencies, in particularly in the nutrition response, in the migration context. And it can be personnel from NGOs, UN agencies, but also the government. So welcome to you all. Next slide, please. Thank you. So I introduce myself. I'm Yvette Fauch, nutrition specialist at the Regional Office for Latin America and the Caribbean in UNICEF. I'm based in Panama. I'm also the migration focal point in the Regional Nutrition Group led by UNICEF, but also the nutrition focal point at the regional level of the Regional Migration Response Plan of the R4V platform led by UNHCR and IOM. Also today, we have with us Caroline Hillary, family physician and public health specialist from Save the Children based in Bolivia, and also Geraldine Belloc and Ben Allen from the Global Nutrition Cluster Technical Alliance. Next slide. Thank you. So before starting, I would like to let you know that we are recording this webinar, so any intervention you will be making in the chat or in the questions will be recorded. Also, we will have pre and post tests, knowledge tests, so before and after the presentation. And these will be confidential, so nobody will see your answers, so feel free to share your answers. And at the end, we will have a question of questions and answers. So we would like to ask you to use, not to use the chat to ask questions, but to use the questions, the Q&A here in the Zoom. In the chat, you can introduce yourself, your organization, the country you're working on, so that we have a sense of who is participating in this webinar. And also at the end, there will be an evaluation of the webinar. An evaluation of the content and also how you feel that your knowledge has improved. It's about also, your experience in this webinar. So next slide, and I give the floor to Caroline.
Yeah, thank you very much. Good morning, everybody, or midday, wherever you are. My name is Caroline, and as we said, we are going to start with a pre-test. Can you launch it? Okay. So you're going to see some questions. If I may ask you to please respond to all the questions, scrolling down until you got to question 5. I'm going to give you a couple of minutes.
Can you see the poll on the screen with the questions and for you to provide the answers?
I see it says attendees are now viewing questions. I hope that that's true. I know it always takes a little while before I see that people are answering. Let me see in the chat. I can see it says Maika Arts. Yeah. Okay.
Yeah, it's starting to move. It's working.
Yep. It has a little bit of delay, the polling. So please, if you can all type your questions into the poll. We have not even half of 40% only have responded so far as I can see. So please keep putting your answers as you think they're true. And make sure you scroll down because there are 5 questions. Couple of more people, if you can respond, please all take your pre-test. It's anonymous. We're not going to see who has answered what. So don't worry. Okay. We have about 80% have answered the pre-test. Some people are joining us just right now. So I'm giving it another 20 seconds and then we'll go over the answers. Okay, well, thank you very much for those of you who've been able to participate in this pre-test. I will now just show you the results. I will not say what was the expected answer or the right answer because that's part of the webinar. So I hope you all pay very much attention to the webinar, and then we'll do the same questions at the end of the webinar. Before implementing nutrition interventions in response to an emergency, data is needed about the nutritional status of the affected population. 74% think that that is true. Question number 2 was men need more iron because they have greater muscle mass. 81% think that that's false, and 19% think that that's true. The third question was on which are specific vulnerabilities for women in emergency situations. You had multiple choice. Most of you marked lacking access to prenatal or postnatal services, but also the other answers got quite a bit high turnaround. The fourth question is, what is a maternal nutrition specific interventions? And you had several options. The highest one here that I can see is nutrition counseling during antenatal control, and the other ones being lower. And question number 5 is, what is not a direct success factor for a micronutrient supplementation program for pregnant and lactating women? And you could only do one answer. And most of you have identified accessibility of fruits and vegetables on the market. I will now stop sharing results. Just to explain again that we will take the very same questions at the end of the webinar. And then there is another survey which is on your satisfaction with this webinar. So watch out for the end. There will be 2 surveys. Next slide, and over to Yvette.
Thank you. Thank you very much, Caroline. So in this webinar, we will be having a short introduction to for some explanations about some myths on the nutrition sector. We will then continue presenting about nutrition during pregnancy and lactation, the consequences of malnutrition during pregnancy, vulnerabilities in emergencies, and maternal nutrition interventions. Next slide, please. Okay, so I will start by clarifying some myths around the nutrition sector. And well, I have often heard from many people working in emergency response that nutrition is seen as the same as food distribution, or at least that there's a perception that food distribution is enough to cover the nutritional needs of the whole population, including the vulnerable one. The thing here is that food distribution is a food security interventions where food items are being distributed to the general population, but that's different from the nutrition interventions the nutrition sector undertakes to really cover the specific nutritional needs according to age and condition. For example, food distribution does not ensure that pregnant and lactating women receive the micronutrients they need, and also the children also receive it to survive and thrive. Also, that does not ensure that mothers are adequately supported to breastfeed in stressful situations, and that the child receives breast milk. And in the case where breastfeeding is not possible, how this child can be breastfed with which alternatives. So we need much more intervention, more specific to nutrition than food distribution. Next slide, please. Okay, this is a UNICEF framework of malnutrition. So we can see that the immediate causes of maternal and child nutrition are inadequate dietary intake and diseases. And the underlying causes are household food security, inadequate care and feeding practices, and unhealthy household environment and inadequate health services. And there are also basic causes, more structural. More structural. So I'm showing this to show you that the nutrition sector focuses on planning and implementing nutrition-specific interventions that target the immediate causes of undernutrition. For example, nutrition counseling before, during, and after the pregnancy, maternal supplementation with energy and proteins and also micronutrients, and also disease prevention with deworming, for example. But also the nutrition sector implements activities regarding breastfeeding and complementary feeding counseling, micronutrient supplementation, children under 5, again, deworming, and identification and treatment of acute malnutrition. Next slide, please. There are also the nutrition-sensitive interventions that are also important, but that are not included as part of the interventions of the nutrition sector. These are the nutrition-sensitive interventions that include agriculture, food security, including food distribution, maternal mental health, child protection, WASH, health, etc. Next slide, please. So that was one myth. The second myth is that data on the impact of an emergency or the nutritional status of the affected population is needed to implement nutrition activities. When we have an emergency, there's an increase in malnutrition, for example, acute malnutrition, and there's a perception or an idea that we need to have a diagnosis and data prevalence of acute malnutrition to really understand the nutrition situation. And once we have this data, once a survey has been conducted, then we can plan for a nutrition response. But that would be too late. Next slide, please. So when an emergency happens, there is nutritional vulnerability, given that vulnerable groups are present. And their nutritional status will be deteriorated, leading to the increase in acute malnutrition. And this is where the nutrition response should start, right when the emergency happens, as soon as possible. It should start with a rapid needs assessment. So where are the vulnerable groups, children under 5 and pregnant and lactating women, and also focus on prevention of malnutrition in vulnerable groups. That's the key word, prevention. We cannot afford to wait the situation to be deteriorated to take action. We need to prevent malnutrition, not simply wait for it to happen in order to respond. And at the same time, it's important also to start detecting cases of acute malnutrition and treat them. So in summary, the key word here is prevention of malnutrition. Next slide, please. Now I'm giving the floor to my colleague Caroline. She will be presenting the section on nutrition during pregnancy and lactation.
Okay, so we are talking now about women's nutritional requirements. In this slide, we're talking about the nutritional requirements over the life course, where, as we can see, there are different stages, particularly the adolescence, pregnancy, and breastfeeding, which have higher nutritional requirements than during other times of life. So obviously, during adolescence, we have a higher need of energy, protein, and micronutrients because we're still growing. Before we become pregnant, as women, we need nutritious diets to establish sufficient reserves for the pregnancy. Then during pregnancy and breastfeeding, we have a higher nutritional requirement in terms of both calories and micronutrients. And in the next slide, I'll go over to more detail. So this again is the life cycle. There are vulnerabilities to malnutrition specific to each time in life. So during the first 2 years, a baby may have suboptimal breastfeeding practices or may not be getting enough complementary feeding, either in frequency or in quality. And there are also in this stage of life frequent infections, which you're all aware of. Then we have the next stage would be early childhood to school age, which is about 2 to 9 years. You may have inadequate food, inadequate health services, particularly intestinal worms that are not being treated and other infections. And we also have obviously health education, which may be inadequate, and education sector in itself. During adolescence, as I was saying, we have increasing nutritional needs, particularly increasing iron requirements, and we may have, unfortunately, early pregnancies. And then during the last box here, which is pregnancy and lactation, we have increasing nutritional needs. We have particularly increasing micronutrient needs. And this gets compounded and complicated when we have short birth intervals between one pregnancy and the next one, if we don't give enough time for women to recover their nutritional reserves. Can we move to the next slide? So in summary, particularly around pregnancy and lactation, we have increasing nutritional needs for menstruation, pregnancy, and lactation, but also because the baby needs some of these nutrients. So we have fetal growth and development. The woman also needs nutrition to defend herself against infectious diseases, and this is particularly important now with the COVID-19 pandemic. And again, I'm mentioning here that during adolescence, these needs increase even more because pregnancy may occur when the adolescent is still growing. So for all of these reasons, women are particularly vulnerable to malnutrition. And to give you some data, during pregnancy, a woman needs 300 additional kilocalories on average per day. And she also needs about 7 additional grams of protein per day. Now, in the last group, in the Spanish-speaking group, somebody was asking, is that animal protein or vegetable protein? And it doesn't really matter. It can be any protein. But for other reasons, for the micronutrient reasons, we do recommend some of it to be animal protein. Now, look at during lactation, when we're breastfeeding, a woman needs 640 additional kilocalories per day during the first 6 months of postpartum, particularly if she's exclusively breastfeeding. Now that's quite a bit, and any of you who have already breastfed will know that we do have quite a bit of hunger. It's about another plate, of what you usually were eating, just, have another serving. To get that, and she needs about 19 additional grams of protein per day. Next slide. So this graph is about iron requirements, and there was a question in the pre and post test about that. You can see the yellow line are women and the pinkish line are men. It's calculated by milligrams of iron per 1,000 kilocalories. And over the lifespan. As you can see, the yellow line and the pink line are pretty much the same during the first roughly about 5 years of age. So there's not a lot of difference between girls and boys. We all start off with a high need of iron when we're small babies, and then it goes down to about 2 milligrams per 1,000 kilocalories, which is what men also need for the rest of their life. But if you can look at this here, starting around 8 or 9 years, when we go into puberty, there's an increasing iron need, and that iron need is higher for the girls than for the boys. We all grow muscles during this time, but the girls particularly are maturing their ovaries as well. And then you can see that the men's line basically stays flat until for the rest of their life. And the women's line, the yellow one, stays higher than the men's need, and that is because of menstruation. And you can see that as women go into menopause, the lines again meet each other and are pretty much equal. But what you have to see here is that this is a woman with only one pregnancy, that during pregnancy we have a very high spike, I think you say, of iron requirements, which are due to forming new tissues in the placenta, the fetus, and also because of the blood loss during childbirth. Next slide, please. So here we talk a little bit about the weight gain that is recommended during pregnancy. This slide is very busy with numbers, and as you're getting these, I'm not going to read them out to you. Just to make you aware that we have the total weight gain, both in range in kilograms and in pounds. Some of the countries that are joining us may be using pounds. And then we have the mean range of, the mean and the range of kilograms per week during the second and third trimester. And now what is important here is that the amount of weight that a woman should be gaining during pregnancy depends on her pre-pregnancy nutritional status as measured by the body mass index, BMI. So if the woman was underweight before she became pregnant, she needs to gain about 0.5 kilo per week to make sure that her nutritional need is fulfilled. If she had a normal weight, it's about 0.4 kilograms per week. If she started off overweight, it's just about 0.3. And if she was obese before she got pregnant, she only needs to have a relatively small weight gain, because we're kind of assuming that she's actually using some of that over body mass that she had to be feeding the child. Next slide, please. So here we talk a little bit about the consequences of maternal malnutrition. And particularly, I'm referring now to undernutrition, both in low body mass index and micronutrients. I will, in this talk, not go into the risks of overweight and obesity. I'll start off with, because we were talking about weight gain during pregnancy, so I'll talk about the lowest range here on the slide. Low BMI and suboptimal weight gain are a risk factor for a delivery of infants which are too small for gestational age, or SGA. And this fetal growth restriction, which means intrauterine, these babies are not growing as well as they should, that is actually a cause of 25% of all newborn deaths, which is a very significant number. It is also important to note that these babies that are born small for gestational age happen both to term babies, but those that are born after 9 months of pregnancies, as well as those who are born preterm. So now I'll go into the specific micronutrients deficiencies. As you can see on this slide, we're going to talk a little bit about iron, which is very frequent to have a deficiency. That has an associated risk of maternal mortality. And for the babies, they can be low birth weight, they can be premature, therefore there's a higher neonatal mortality. And of course, the transfer of iron to the fetus is reduced because the mother doesn't have enough iron herself. In terms of folate, we see an associated risk to low birth weight and also to neural tube defects, which you know as spina bifida and anencephaly. In terms of vitamin A, if the woman is deficient, she may have night blindness, but her risk of antepartum hemorrhage, bleeding, and therefore maternal mortality is also increased. The baby may have a low birth weight and therefore an increased risk of infant mortality. The next micronutrient is calcium. There are a lot of studies now very well demonstrated that calcium deficiency is associated with preeclampsia, which is high blood pressure due to pregnancy, and that can be associated with both maternal mortality as well as neonatal mortality. And the last one is iodine. We don't see that deficiency as much anymore because the iodinization of salt has been pretty much universal. But we sometimes do see maternal and fetal hypothyroidism. And what is important about iodine is that if you have that deficiency during pregnancy and the mother gives birth to a baby that has an impairment of the neurological development of the brain, that impairment is totally irreversible. So even if you give that baby loads of iodine, it's not going to recover because the damage has been done during the embryonic stadium. And it can be a spectrum of a full cretinism in the baby to a rather low or even difficult to detect delay in neurological development, brain development. The next slide. And please, if you have any questions, put them in the question and answer box, not in the chat box. I will take them later during this webinar. So now I'm going to talk a little bit about increased vulnerability during emergencies. As you're all aware, during an emergency, there is typically or oftentimes a limited access to food, but we also have a limited access to health services. And particularly for migrant populations that we're seeing now in Latin America, there may be a specific limit to access anti and postnatal controls. So while in most countries, if a woman goes into labor, she will access childbirth or even cesarean section services, but she may not have the right to access an ante or postnatal control, depending on the country that she is living in or migrating to. Furthermore, because of the living conditions during emergencies or during migration, we may have limited access to water and compounded with less access to hygiene and sanitary conditions. And you may say, well, that's kind of like the same thing for men and women. That's true, but women have, by physiology, a higher need to hygiene, to particularly sanitary conditions because of menstruation, but also due to social reasons. Typically, women are doing the cooking and taking care of the smaller babies, and therefore need more access actually to hygiene. Due to this limit of access to water and hygiene and sanitation, there is increased diarrhea during emergencies and infectious diseases. And that in itself causes malabsorption of the nutrients and sometimes nutrient loss. So if somebody has diarrhea, the nutrient just goes out and is not able to, even if she's eating quite a bit or getting a supplement. Following all of that, we all know that gender-based violence increases during emergencies. We see increase in physical violence, feminicide, sexual violence that is related to adolescent pregnancies, and of course other types of violence that increases in this irregular situation during an emergency, particularly if the woman is displaced. Finally, I'll talk a little bit about maternal stress. All of these conditions, that lack of access to food, water, and the violence and the emergency itself causes stress. And that causes cortisol to increase in our body, which is a hormone, which is actually good for us because it makes us be able to react and run. But this is typically the emergency is a situation where running is probably not the best thing to do. And we need to remind ourselves that cortisol levels circulate in the mother's blood. If she's pregnant, it also goes into the uterus and affects the baby. So it affects both fetal growth, but particularly it affects the brain development of the baby. And so all of these conditions make us having a nutritional vulnerability and a risk of malnutrition that is more in women and children compared to adults and men. And with this, I think I hand over to my colleague Yvette. Next slide. Thank you.
Thank you, Caroline. Very, very interesting. Okay, so now I will present the maternal nutrition interventions. So interventions to prevent the deterioration of the nutritional status of pregnant and lactating women, but also an intervention to address malnutrition in this vulnerable group. So we'll be looking at multiple micronutrient supplementation, deworming, weight monitoring or middle of arm circumference measurement, nutrition support through balanced energy protein supplementation, and nutrition counseling. Next slide, please. Well, first of all, we have to acknowledge the COVID-19 context and that we need to take IPC measures, so infection prevention and control measures that include hand hygiene, personal protective equipment, such as medical mask, eye protection, and wearing a clean long sleeve gown and gloves. It also requires respiratory hygiene and cough etiquette, cleaning and disinfection of devices and environmental surfaces, and supply storage and handling adequately to prevent infection. Next slide, please. Okay, so the first intervention that I present now is multiple micronutrient supplementation. That is given to prevent micronutrient deficiencies and prevent also the consequences that Caroline just presented on maternal and child health. This supplementation is given once per day from the first day of care in pregnancy and up to 6 months of breastfeeding. And it should contain at least iron and folic acid. But given that it's multiple micronutrient supplementation, it contains several micronutrients. Next slide, please. And now there's stronger evidence to support the use of multiple micronutrient supplementation vis-a-vis iron and folic acid supplementation. Given that there has been, there's evidence of reduced risk of stillbirth, low birth weight, small for gestational age, and preterm births. And this is information from the Lancet series of maternal and child nutrition that was just released last week on Friday. Next slide, please. The second intervention is deworming prophylaxis. So it's really to reduce the burden of worms caused by soil-transmitted helminth infections. So the recommendation is to give a single dose of albendazole or mebendazole. Compared to the micronutrient supplementation, it is not given daily, but only a single dose. Next slide, please. It's also important to conduct weight monitoring. So here we see a picture of a woman where we're taking her weight. Apologies for the picture, it's not in the COVID-19 context, but at least it gives you an idea of the activity. So the idea is really to calculate the body mass index based on the weight and height, and identify mothers or women with being underweight. And because these mothers will need nutrition support. We will see it in a few slides. Next slide, please. Another possibility is to conduct MWAC measurements. So with a MWAC tape, a mid-up arm circumference tape. So there are no international standards on the definition of acute malnutrition for malnourished pregnant and lactating women, but these are, but cutoffs have been used in the past in several countries. And the cutoff that has been used is to below 21 or 23 centimeters. And the women identified with malnutrition based on these cutoffs will also need nutrition support. Next slide, please. Okay, so now taking into account the COVID-19 context, what is best? To use digital scales or to use a MWAC tape? When you use a digital scale, these are safer in the sense that the scale allows the mother to stand on the scale with shoes with no need to touch. And the turning function is automatically initiated, so you don't need to touch any button. However, this is different using a MWAC tape because there's contact between the mother and the healthcare provider, and also contact with a surface, which is the MWAC tape. So the MWAC tape can only, it is recommended that it's only used if the MWAC tape can be disinfected after each use, or if it's a single-use MWAC tape, and there are enough. And of course, the healthcare provider needs to wear personal protective equipment, but that's also in any case with digital scales or with the MWAC tape. Next slide, please. Thank you. So now comes the nutrition support through energy and protein supplementation. So once we have identified women with undernutrition or underweight, we need to support them. So this is a daily ready-to-use paste that is high energy and fortified to treat malnutrition in pregnant and lactating women. And it can be used from the sachet, so no cooking or dilution is needed, and it promotes the fetus growth in underweight pregnant women. So this is a picture of the product that may remind you of the plumpy nut for the treatment of acute malnutrition in children under 5. But this is for pregnant and lactating women. Next slide, please. And also a very important aspect of nutrition intervention is nutrition counseling, where all the nutrition interventions are also or should also be covered, well, including counseling on nutritious diets. So how to, which foods to consume based on which foods are locally available and affordable. An important element is to counsel on micronutrient supplementation, on its importance, and also to take it daily. Another important element is to monitor the weight and to counsel an appropriate weight gain. And the last is, well, to support underweight women with energy and protein intake, and also recommend an energy and protein supplementation for underweight women. Next slide, please. Now, it's very important to take into consideration the COVID-19 context, where health services are disrupted. And well, it is important to prioritize antenatal care contacts for pregnant women in the 3rd trimesters, also adolescent girls and underweight women. It is important also to schedule these antenatal contacts to reduce overcrowding, and also to provide all the relevant care in one single visit. And also where antenatal and postnatal contacts are reduced because of the disruption of health services, it is suggested to provide supplementation for several months, so for 2 to 3 months. So also to avoid contact. Next slide, please. Okay, and an important aspect of the success of supplementation depends on the continuous supplies. So it's important to assess correctly the supply needs for our target population. It is important to have a distribution system accessible to the target population, and to think, for example, if the health system is disrupted, what is the best way to reach the target population? An important aspect also to take into consideration is women's compliance, and for that, community communication may be needed. So to really, and counseling, of course, to really make these women understand the importance of supplementation. And the last point, also very important, is to have adequate human resources, adequately trained. Next slide, please. Okay, now we move into the migration context. So here I am presenting the maternal nutrition interventions through 3 different points in the migration transit. So the first point is at the borders, so in shelters. This is very general. This slide is very general. It will depend on your context, of course, and it should be adapted to your specific country or context. So the first activity that should be implemented in shelters is to identify pregnant and lactating women, to know how many they are and where they are. That would be easier to reach them. Also to monitor their weight or measure their MAC to identify malnourished women. Also to provide energy protein supplementation for malnourished pregnant and lactating women. To provide nutrition counseling. To give deworming medication. To provide macronutrient supplementation. And also a very important aspect is to communicate on the available nutrition services, how and where to access them. And it will be important to take into consideration the language these women or refugees and migrants speak. And here I am including, mobile clinics as a potential platform. that has been used in some countries, such as Colombia, and has given positive results to reach the target population. Now, what to do with refugees and migrants that do not stay in shelters, but that continue their way. This population is a bit more difficult to reach, but there is a way, is to identify them at the border and provide them with micronutrient supplementation or energy protein supplementation for malnourished pregnant and lactating women. And the idea is to estimate the number of days these women will take to reach their destination or the next border or the next place where they will receive support. So this is a way to supplement, to support the nutrition of these women on the move. When there's no point, let's say physical service point. And the last one is host communities. So this is where refugees and migrants are with host communities. So maybe less it's a bit more difficult to identify them. So it's really important to have communication targeting them on available nutrition services, how and where to access them, again, in their language as well. It's important also to provide nutrition counseling, deworming, micronutrient supplementation, and also perform weight monitoring and provide energy protein supplementation for malnourished women. And here, the platform delivery could be healthcare facilities, antenatal and postnatal care. And we should take also into account the COVID-19 context, that we should prioritize the continuity of maternal nutrition services. So here, advocacy would be important, an important action. It will be also important to maintain uninterrupted the availability of essential nutrition commodities. So the supplies we have present. Next slide, please. Thank you. Here I'm providing examples of nutrition-sensitive interventions. So these are interventions that may not be led by the nutrition sector, but that are also important to reach nutrition results. So the nutrition sector, or you as nutritionist or working in the nutrition response, can work with health to advocate to have access to health services to refugee and migrants, with priority to pregnant and lactating women and children under 5. You can also work with the protection sector to improve maternal psychosocial well-being and support, and also to expand the social protection programs. You can also work with WASH to ensure hygiene and sanitation to reduce parasitic infections and diarrheal diseases, and also food security, a very important one, to give priority to pregnant and lactating women in food distribution, and also to discuss about the quality of the food being distributed. Next slide, please. So in this presentation, we gave you a brief overview of the main nutrition interventions and to conduct the nutrition response in the context of COVID and migration, but you can also access other resources from WHO, and also resources to support decision makers and implementers on how to prepare and respond to the COVID-19 pandemic while protecting maternal diets and nutrition. And finally, the third Lancet series on maternal and child undernutrition that was just launched on Friday last week. So it is fresh with updated information. Next slide. So I give the floor to my colleague Caroline for the post-webinar evaluation.
Okay. Well, I hope you're all ready. These are the same questions. Ben, can you launch the poll, or I can actually do this? No, yeah, I'll have you launch it. Thank you very much. These are the same questions, just Even if you haven't taken the pre-poll, please enter your questions, your answers now. By reading through the same questions, it should be easier and clearer and than at the pre-test. I also want to make an announcement. We do these webinars both in Spanish and in English. So if you prefer to join the Spanish section, I see some of you are from actually Spanish-speaking countries. These are an hour and a half before the English version. You can do so and get the appropriate link for the Spanish version. And I'm sorry, pour les collègues haïtiens, that we're not offering this time in French. We'll speak about it in a minute. Couple of more minutes. We have half of the participants, just about half, who've responded. Please all enter your answers. You will not be graded. I can't see individually how you're responding. We just want to see some of the learning. And also don't forget that at the very end of this webinar, after our question and answer session, we have an exit survey about this, your satisfaction about this webinar. So there are two different surveys. The one that we're taking now is technical, and the last one will come up when you leave this webinar. We're at about 80%. Okay, I guess those are the people that are taking the poll. I will stop it now and share the results with you. Can somebody just say if you're seeing it?
Yes, we can see it.
Okay, thank you. All right, so question one. There still seems to be a little bit of doubt. So I repeat this again. Before implementing nutrition intervention in response to an emergency, data is needed about the nutritional status of the affected population. The answer that we were expecting here is false, which only 37%, 15 of you have gotten it. Yvette has explained at the very beginning of our presentation that this is a myth, meaning sort of a false idea among many people in the humanitarian and the nutrition sector, that they think we have to start off with getting data, otherwise we can't do anything. That's not true. I think she's insisted quite strongly about we can do prevention of undernutrition even before we get any data. After the poll, I'll hand over the microphone to Yvette to clarify anything more about this point. The second question was, men need more iron because they have a greater muscle mass. All of you have responded that that is false. Actually, women need more iron because of the physiological needs that we all have. The specific vulnerabilities for women in emergency situations, these were several answers were possible. You had a multiple choice, and actually all of these are true. So you were supposed to click on gender-based violence because it's a specific vulnerability for women. Lacking access to prenatal and postnatal services, obviously specific for women. Maternal stress is something that we discussed. Lacking hygiene and sanitation, as I said, there are specific needs of women that are not met during the emergency, and women have a higher micronutrient requirement that we've gone over. So all of these were true. Question number 4, what is a maternal nutrition specific intervention? As you may remember, we differentiate between specific and sensitive. And again, you had multiple choice. The correct answer is deworming pregnant and lactating women, because that is specific to nutrition and nutrition counseling during the antenatal control. The other 3 interventions, which some of you marked, are important and they're nutrition favorable, but they're usually not done by the nutrition sector, and they're not specific to the nutrition needs of vulnerable populations. So distributing food to families, it goes to everybody. Distributing soap and alcohol, again, to families, that is used by everybody. And improving water access, while it is more important for women, but it's not considered nutrition specific. It's nutrition sensitive. Question number 5 is actually quite clear. What is not a direct success factor for micronutrient supplementation program for pregnant and lactating women? You were supposed to give only one answer, and most of you got this right. It's the accessibility of fruits and vegetables on the market, because while that is important for micronutrients, but it doesn't really have much to do with supplements. Again, repeating, the uninterrupted supply chain is important, because even if you make a big communication campaign about how to take your supplements, it's not going to have any effect if the supplements aren't in place. On the other hand, if the supplements are in place, but you don't have communication with your clients or users, it's not going to be of much use. The training of staff who distribute supplements is very important, because they have to give out the correct information about how the supplements are going to be taken, and some other like adverse effects or so. And the last one, the quality of the supplement is also very important, because if the quality is poor, for example, I've seen iron folate pills which crumbled. You know, they were just sort of like a powder when they came out of their blister. Then of course people are not going to take them, or they may have another adverse effect. So these were the results. We're now going into our question and answer session. I have already answered a couple of questions that were raised, but I'm handing over to Geraldine, who is having a better read of what's going on in the question and answer box.
Yes, thank you very much, Caroline. And thank you very much, both of you, Yvette and Caroline, for the presentation, very clear. So it did raise some questions, some very technical and precise questions. So yes, Caroline, you have answered them direct to the person. So now we can share also some of these answers to the group. So the first one I would like to ask you is coming from Lydia, and she's saying that in most of the countries, in fact, the common micronutrients available are iron and folate for pregnant women. But then you speak about multiple micronutrients. What is your recommendation?
So should I just go ahead and?
Yes, please.
Yeah. Okay. Right. So the most important micronutrient for women who's pregnant is actually our iron and folate. So if that's what you have, that's fine. Just make a supplementation program with iron and folate. If, on the other hand, you have the possibility to acquire, to buy multiple micronutrient supplements that are specific for pregnant women, then those would now be recommended. Now, what I do have a caveat there. What is not recommended is to double. So don't give women iron plus micronutrients, multiple micronutrients, plus vitamin A, plus calcium, because that could be actually dangerous. Particularly with vitamin A, we have to be a little bit careful. So the product that you're purchasing has to say this is specific for pregnant women, and only give one. So it's either iron, folate, or multiple micronutrients. And I wouldn't start on like getting loads of different kinds of tablets. It's just confusing, and it can cause toxicity. Yvette, do you want to add something to that?
No, I think you replied to the main elements. But maybe I would retake the first question concerning the data to have before an emergency, if I can. Yeah, okay, thank you. So it is true, it's important to have data before the emergency, but not data on, not prevalence data, I mean, we shouldn't wait to have the results of a fully fledged survey to start a nutrition response. The idea is to have, at the beginning of an emergency, a rapid assessment to really understand where are the vulnerable populations and how we can target them. And based on that, we can estimate the needs. But the main message here is that we cannot wait for the situation to deteriorate and have evidence of this deterioration in order to act. We need to prevent this deterioration. So this is why we need to implement nutrition preventive, interventions to prevent malnutrition right from the beginning. That's all.
All right. And jumping on this subject, Yvette, do you have tools to support the evaluation of needs, calculation of the target population, and also supplies need?
Yes, thank you. We have some tools to identify the main, to conduct a needs assessment. For example, in shelters, not only about the number of pregnant and lactating women and children under 5, but also what are their conditions. And well, it was the same question asked in the previous webinar, and it's I think we can work on a tool on how to estimate supplies. I think the idea is to really have the people in need in mind, and then to decide how many people from these people in need we can target, and from this estimate the supplies, also for the length. For how long are we going to provide? We are not hiding that this is difficult in a migration context that is changing. Migrants are leaving, are coming. There's no ideal way of estimating it, but there are some tools that we can definitely share for you to adapt to your country.
Fantastic, thank you. Then back to Caroline, maybe for this question. Regarding the recommendation of micronutrient per pregnant woman or per lactating woman or per infant, which kind of recommendation do we follow? Do we follow SPHERE standards? Do we follow any other standards to calculate the needs per person per day based on our target population?
You typically don't really need to calculate each person's individual need. I mean, that is something that, you know, how do you say, a clinical nutritionist would do that. But as public health practitioners, we look at big programs for everybody the same. So for all women who are pregnant or lactating, we should have a supplement that has at least the 30 milligrams of iron and the 400 micrograms of folate. Now, if you get, as I said before, if you get something like a multiple micronutrients supplement, it's available in the country and you can buy it and it says it's for pregnant women, that would even be better. But it's more likely to be also more expensive. So think about how you're going to spend your money. Now, about children, we're going to talk in the next webinar. But the products are also already, they come already calculated for children under 2. You know, you have the sachets of the micronutrient powders. You have the whatever the vitamin A capsules if you're still using those, etc. So products typically come already pre-calculated, particularly the Plumpy Mom that we've shown in this presentation. I repeat, it's thought for only for malnourished pregnant women. So if a woman is pregnant, but her body mass index is fine or her MUAC tape is okay, you don't need to give her this supplement. It's not indicated. And in terms of water and hygiene, you should just follow the SPHERE standards. That was fine.
Okay, super. Excellent. So Yvette, maybe you know the answer. Are there any medical health application to use in this case of emergency, which is migration and COVID? And or do you know anything, any application that helps to collect data and evaluate the effectiveness of the intervention?
Thank you, Geraldine. No, I don't know any of these apps. We can check with the health sector and our health colleagues to see if they have something similar. I mean, what would be useful more than an app to evaluate the effectiveness of intervention would be maybe to collect, or at least, yeah, to collect some data on the refugee and migrant population, in the sense that migrants would receive interventions at the border, then at the communities, and then along the transit. And this could be documented in a way. I don't know if it should be online in an app. There may be, difficulties also in managing personal information, but or simply in on paper in a booklet, so that we can really insert the intervention that the pregnant and lactating women received, and that they can take it with them to the following point. Actually, this is something that was discussed at some point to really have a continuity.
Yeah, interesting. That could be helpful.
Yeah, maybe to add, a lot of projects are actually using Kobo type of, on a cell phone to collect data, but each one of them is doing kind of like their own format. Now, to put data on a cloud and follow up somebody who is migrating, let's say from Venezuela through Colombia, through Central American countries, I think there'll be a lot of both technical and data protection issues. I don't think that's so easy. So I think the use of technology right now that we would definitely recommend is within a project. So as you know, staff that lives in a certain area and is attending a defined population, yes, you know, go ahead and install stuff and you know, to get rid of so much paper. But I wouldn't recommend, you know, that's difficult enough in itself. And I think the idea is great of that Yvette was mentioning, that the woman should actually have some record of what was done when she was in shelter A, so that when she moves to shelter B, the person who is then taking charge of her can see what she has received. That would be really great.
Yeah, good point. So I do have a question specifically on deworming, and could taking deworming prophylaxis during pregnancy be a risk on the fetus?
Okay, yeah, we had that question in Spanish too. So, and I understand it because I've studied medicine myself, and we were taught that, you know, mebendazole and albendazole cannot be given to pregnant women. But the research actually shows that we're not recommending it for the first 3 months, or if you want to go to the safer side, until week 20. After that, the baby is basically formed, and it's now called a fetus, not an embryo. And all its, you know, the body is actually there. It's just sort of growing and getting more muscles and so forth. Then at that point, deworming is perfectly safe. Many studies have been done, and it's okay to deworm a woman with either mebendazole or albendazole, as I said, starting on the 2nd or 3rd trimester.
Okay, great. That's clear now. So Anne-Marie from IT is asking if there are any guidelines for multiple micronutrient supplementation for pregnant women specifically, and for how long the supplement will be given.
Yes, merci Anne-Marie. Actually, we have, I have presented a slide on guidelines from the WHO, and also other resources, including the Lancet series on maternal and child undernutrition that were released last week. And also have more resources on that we can definitely share. And the idea is to give micronutrient supplementation, I mean, at least in this context, I mean, at least at the first contact with a healthcare provider, with a pregnant woman. And it should continue until the first 6 months for a lactating woman. Although, I mean, in a development context, it is also suggested that women are supplemented at least 3 months before to ensure positive nutrition results, nutrition and health results. So we can definitely share the guidelines with you.
Okay, super. And now there is also a very short question about MUAC in women to detect malnutrition. And what is your recommendation for the cutoff, 21 or 23 centimeters? Maybe Caroline, you can help us with that.
Yeah, I think we need to come to a close. I actually gave repeated that there is no official consensus. Like there's not you know, there's not a consensus of the international community as we have it in MUAC for children. The thing is that it is obviously difficult to get to a global consensus because, as you can imagine, women in India, for example, or in Nepal are typically very skinny. And so the MUAC cutoff may have to be adjusted. So the question was, should we use 21 or should we use 23? And because I knew that the person who was asking the question was from Venezuela, so doctora, muchos saludos. In Venezuela, if you ask me personally, I would use 23, because these women come from a nutritional status where overweight and obesity was very prevalent before just a couple of years ago. So I would use 23 in that context, but it really depends on your context. I don't know if Yvette wants to add.
Yes, thank you, Caroline. I agree with you, and also this is something you can decide in your country. You can, I mean, really discuss in the nutrition sector or with nutrition and health, and really decide based on your specific context which one of the cutoffs you would be using.
Okay, great. Thank you very much. Thank you very much, all participants, for your questions that were very nice and yeah, very much important. And I will give back the hand to Yvette to close this webinar.
Yes, thank you very much, Geraldine. Well, thank you very much to all the participants. We had great participation today. I hope the presentation provided was helpful to you. So please complete the evaluation form for us to understand what you liked, what was useful to you, what you would have liked seeing, and how we could improve in general this webinar. I have noted that you would like to receive resources as well as a presentation. So you will receive it, and you also will receive the recording of the presentation. So you will have the whole pack. So again, thank you to all, and hope to see you next week for the webinar on prevention of malnutrition in children under 5. And I hand over to Caroline for last comment.
Just to say goodbye, and I repeat, see you all next week, same time. If you want the English version, if you want the Spanish version, it's a little earlier. We will be sharing with you about child nutrition next week, and then about malnutrition in 2 weeks' time. Have a good afternoon, everybody, and bye-bye.
Thank you.